So welcome everybody as you're coming in. This is great. We're going to give it a couple of minutes to let the majority of people join, and we'll get started in about 1 minute. Hello, welcome everybody. We're about 2 minutes after the start time, and you'll see that that attendees are joining us. And so while they come on in, I'll start doing some housekeeping and introductions. Welcome today. My name is Shoma Ghosh, and I'm an Associate Vice President here within the Behavioral Health Group at WestAT. I'm also part of the leadership team of the SAMHSA Center for Financing Reform and Innovations contract. We call it CFRI for short because it rolls off your tongue. I'm joining this webinar here today from my hometown of Appleton, Wisconsin, where I'm sure nobody's very surprised to hear we're blanketed in snow right now and it's 20 degrees. Appleton's about 20 minutes south of Green Bay, if anybody's wondering. I'm so pleased to welcome you all to today's event. I have personally dedicated the last 2 years of my career to trying to improve the US behavioral health system and in lots of different ways. And the webinar today is really important to me. The webinar is called Examining the Use of Braided Funding for Substance Use Disorder Services. And it focuses on ways to improve access and financing of substance abuse disorder treatment and related services. I know this is important to many of you also. We had over 1,300 people register for this webinar today. That's 1,300 people. That's a lot of people. And you can see by the participant counter that the number just keeps going up. So this is really exciting for us. A few quick housekeeping items. So this webinar today is going to be recorded. The recording alongside with the slides will be posted on the SAMHSA website within 10 working days. In addition, all of you will receive an email that will point you to the SAMHSA website and the location for the recording and the slides. Another thing I'll mention is that with the exception of our speakers, everybody coming into this webinar today will be coming in on mute and your video will be off. And that's just so we can maintain a really high quality of recording for this webinar. I'd like to draw your attention to 2 items on your webinar console. One is the Q&A widget and one is the chat one. So the Q&A, I want you to use that to ask questions of our speakers. You can ask questions throughout the webinar at any time as they come to you. Many of you, as a matter of fact, submitted questions as part of your registration. And that is great. And we actually gave those questions to our speakers and panelists, and they are going to try and incorporate the answers to those questions as part of their presentation today. If you submitted a question and you don't see it answered, please go ahead and use the Q&A and ask other questions. Additionally, if you're having technical difficulties, also use the Q&A to let us know. We have people working behind the scenes and they'll be responding to you throughout the webinar, and they're there to help. The chat is the feature that is there for you guys to talk to each other. And I want you guys, it's the main mechanism for, participants of this webinar to interact. And I would love it if you guys went ahead now and used the chat to let people know who you are. And I know it's been a crazy weather week, so tell people what the weather is where you are today. So a few things, Mustafa, if you can put on the slide that shows sea fry. There we go. I'd like to tell you a little bit about this webinar and how it is part of the Center for Financing Reform and Innovation contract, the CFRI contract. So CFRI is a Federal Substance Abuse Mental Health Services Administration contract, SAMHSA contract, and the prime contractor is Westat, which is headquartered in Rockville, Maryland. We're an employee-owned company, and we focus on research and technical assistance. The CFRI contract is actually one of my favorite projects of all time. I've worked on this project over several iterations, and we get to do all kinds of fun projects related to mental health, substance abuse, prevention, treatment, and financing. I encourage you guys to go to this website that's listed on the slide here, which is https://www.samhsa.gov/CFRI, CFRI. And there you'll see descriptions of our other reports. We actually have 18 projects, so we are busy and we're doing exciting stuff. You'll see some of the other reports that we've published, but you'll also see upcoming webinars in our series. And we actually have one coming up in March. On March 26th, it's called Financing Peer Recovery Support Opportunities to Enhance the Substance Abuse Disorders Peer Workforce. It's going to be great. Mustafa, we can go to the next slide now. So, oh no, the one before. There we go. Today, the way we have this organized, you're going to hear from a number of very important and talented people in the field. You'll hear from my colleague and good friend, and actually a co-lead on this, the leadership group for the Center for Financing Reform and Innovations CFRI project, Mustafa Karakas. He's an associate director here at Westat, associate vice president at Westat, and he's going to describe how, give you an overview of this really exciting report that was published today from SAMHSA. Then we're going to move to braided funding, to do a panel discussion about braided funding that's going to be moderated by my longtime friend, John Easterday. He's the former Mental Health and Substance Abuse Commissioner for the state of Wisconsin. He also is from Wisconsin, and he knows all about the weather here. But before we get to any of that, I'd like to turn it over to Dr. Ingvild Olsen for some opening remarks. Dr. Olsen is the director for the Center for Substance Abuse Treatment at SAMHSA. She has a long history of working in the addictions field to expand access to care and enhance quality. She has written and lectured extensively on opioid use disorders and its treatment, the stigma of addiction, the integration of behavioral health and medical care, and clinical and policy solutions to the overdose epidemic. She was previously the vice president of the American Association of Addiction Medicine, president of the Maryland Association for the Treatment of Opioid Dependence, and the president of the Maryland DC Society of Addiction Medicine. She is also a practicing physician and works in an opioid use disorder treatment center in Baltimore. Dr. Olsen, I'll open it up for you.
Great. Thank you so much, Shoma. And it is amazing to see just the range of people who are here from far and wide and cold and sunny. I am sitting in Baltimore in Rockville today, where it is sunny, but I'm cold. So I wish I were somewhere where somewhere with you all who are warmer. But it is really great to be here. And you know, I think as Shoma mentioned that this is a really important topic for us at SAMHSA, because finding innovative ways to use funding efficiently and effectively is really important. And understanding then the benefit of funding models such as braided funding, where multiple funding streams are woven together in a way that makes services seamless to clients who are seeking life-saving care is critical. And so I'm just grateful to join you today for this webinar and to discuss some of the great work SAMHSA is doing through our Center for Financing Reform and Innovation, or CFRI, as you've heard about. We have many projects underway, as you've also heard, as well as some that we've already released. In the past months, SAMHSA released reports and hosted webinars on topics such as coordinated specialty care for first episode psychosis, costs and financing strategies, exploring value-based payment for substance use disorder services in the United States, and then a third report on Medicaid coverage of medications to reverse opioid overdose and treat alcohol and opiate use disorders. And to learn more about these and upcoming projects, please visit SAMHSA's CFRI webpage at the link that, that Shoma highlighted just in her last slide. So as I mentioned, today's topic really is important to SAMHSA because braided funding for substance use disorder services is a funding strategy that allows states and service providers to optimize resource allocation, promote sustainability, and improve outcomes. That aligns with SAMHSA's mission for behavioral health treatment, which is supporting better outcomes for the people that we serve. And so we hope that the report and our discussion today will give you some ideas for implementing braided funding in your organizations. Together, we can advance the types of innovative solutions to really improve the quality and cost effectiveness of substance use disorder treatment and recovery services nationwide. But before I turn this back over to Shoma and our distinguished panelists and to all the work that and what you're going to hear, I really also want to thank my colleague Michelle Monroe within our Center for Substance Use Treatment for making this report and webinar a reality. I also want to thank today's speakers and expert panelists, Stanford, Vicki, and CJ for their time and expertise. And a special thanks to WestDOT for the work that they're doing through CFRI. I also want to thank you all for taking the time to join us today to learn more about these types of funding models and to really learn about the benefits from professionals in the field who are currently using braided funding. And so with that, I will turn it back over to Shoma.
Thank you so much for your comments. And I have to echo, like, I love that you guys write in this chat. It actually makes me so happy. And I mean, the one from Hawaii just reminds me of, like, that's totally paradise. It's like the nicest place ever that I've visited. Okay, so next up, we're going to have my colleague, Mustafa Karakis, who's going to go over some of the highlights of this newly released report from SAMHSA. It was released today. And so, Mustafa, I will turn it over to you.
Thank you, Shoma. Hello, everyone. I'm very happy to be giving an overview of some of the important findings of the study on braided funding for substance use disorder. This report that came out today was designed to help states and program managers better understand the use of braided funding to support services for the treatment and prevention of substance use disorder. And as a reminder again, this report has been posted on the CFRI webpage at samhsa.gov/CFRI. Blended funding and braided funding are two distinct approaches to financing social programs or projects, often within the context of public sector initiatives. And before we start, I just wanted to review these key terms with you so that we are all on the same page about braided funding. Braided funding occurs when one or more sources of funding are used in a coordinated fashion to support a single individual or a program. The different sources retain their specific spending requirements and are kept separate for reporting purposes. And this is different from blended funding, which is when those funding sources are combined into a single pool and become a subject of single set of spending and reporting requirements. As you may see it, each of these funding methods have their unique pros and cons. Ultimately, the choice between blended funding or braided funding depends on various factors, including the specific goals and requirements of the program, the availability of funding sources, and the capacity of stakeholders to manage and coordinate resources effectively. This report showcases case studies from 8 diverse US states: Arizona, Kansas, Maryland, Michigan, Ohio, New Mexico, New York, and Nevada, to exemplify the strategic utilization of braided funding in overcoming the complexities of integrating substance use disorder treatment funding streams. With a deliberate focus on geographic representation and a mix of state and provider level braided funding initiatives, these case studies offer insightful examples of effective resource coordination and allocation. The report also pulls together the information from across the literature and the case studies to summarize the benefits and challenges of braided funding. Some of the benefits we found were that braided fundings can help optimize resource utilization. It can facilitate the strategic leveraging of various funding sources in tandem, maximizing the efficiency and effectiveness of resource allocation. By pooling resources from multiple streams, administrators can address funding gaps and optimize program delivery. It can also aid in sustainability of the programs. So diversifying funding sources through braided funding may lead to greater financial stability over the long term. This approach mitigates the risks associated with relying solely on a single funding stream, thereby safeguarding program continuity and sustainability. The collaborative nature of braided funding can also foster the development of enduring partnerships among the stakeholders. These partnerships not only strengthen program implementation, but also contribute to long-term stability and resilience in the face of evolving challenges. Braided funding can also improve outcomes. Programs supported by these braided funds can be better equipped to offer a comprehensive array of services for the treatment and prevention of SUD. It can also address the service gaps. It can play a pivotal role in bridging service gaps within SUD treatment and prevention initiatives. By integrating resources from various sources, programs can more effectively address underserved populations and regions, ensuring equitable access to essential services. While braided funding offers numerous advantages, it also presents several challenges that warrant attention. The most common one is the administrative burden. It is a primary challenge associated with braided funding. It arises from managing multiple reporting requirements across various funding sources. Administrators and providers alike must navigate complex regulations and understand the specific limitations of each funding stream to ensure compliance and accurate billing. Unpredictability. Braided funding introduces a level of unpredictability into program planning and implementation. Providers may struggle to forecast the availability of grant funds, other time-limited sources, leading to uncertainties in budgeting and resource allocation. It can also have reduced fungibility. Funds may experience a reduction due to administrative requirements linked to one or more funding sources. And also evaluating the outcomes is a little complex. Evaluating the effectiveness and return on investment of braided funding programs can be challenging. With multiple funding sources contributing to a single program, disentangling the impact of each funding stream on outcomes becomes difficult. But despite these challenges, proactive measures such as streamlined reporting processes, improved communication among stakeholders, and enhanced evaluation methodologies can help mitigate these drawbacks. Now, we will be doing a little poll, quick poll with everyone. Now that we have introduced the topic and explained a little about our report, we'd like to know a little bit more about our audience. We are going to launch a poll, as you may see, you should have on your on the webinar. Your options, we would like to know where you are in the process of implementing braided funding for SUD services. Your options are considering braided funding, in the planning stages, currently implementing, or this does not apply to you. Let's give 30 seconds to everyone. Are we all done? We will be showing you the results within 10 seconds. All right, thank you for responding. So we have about 39% considering braided funding. About 9% of you are in the planning stages. 22% of you are currently actually implementing, 1 in 5 participants. And for about 30%, this does not apply to me, but we welcome your presence. Thank you so much. We'll close this. Now we are going to turn things over to John Easterday, who will moderate our panel today. Thank you.
Thank you, Mustafa. My name is John Easterday, and I'm, as it was said before, I was former administrator of mental health and substance abuse services for the state of Wisconsin. I did work after that for Truman and Westat on CFRI. And before that, I was also a provider at the county level, which is important in Wisconsin, for Washington, Milwaukee, and in Dane County. So I do know what it's like, I guess, on the way on both ends. I would like to introduce our panel today. First off is CJ Loisel, who's the Deputy Assistant Director of the Arizona Healthcare Cost Containment System. Also, we have with us today Vicki Walters, Executive Director of Maryland's REACH Health Services Program. Our third panelist, who I understand has not been able to join us today, was Stanford Kemp, Operations Director at the New Mexico Behavioral Health Collaborative. Sorry that you couldn't do that or join us today. Before we begin with our panelist discussion, I'd just like to go over a couple ground rules. One, I'll generally introduce who's going a question to a particular individual, but when I do that, it's certainly welcome for the other panelists or myself to jump in and make additional comments or ask a couple questions if we like, because this is more of a discussion than just a lecture presentation. So with that, I'd like to start with our first question, and this one's for both of our panelists. Please give us a brief description of your braided funding program, the funds that are braided, and how long has the braided funding programs been operating? What was the driver or impetus for braiding your funding? And how are the sources of funds braided administratively? So for this question for both of you, I'll first turn to Vicki.
Hi, thanks, John. So I guess I didn't even realize I was doing braided funding until I got the call from Westat, and we started talking about it, and I was like, oh yeah, we are doing this. So currently we have federal grants and local grants, federal, I don't think we have a state grant right now, but federal and local grants. And then we have partnerships with our community universities, University of Maryland, particularly at the School of Social Work, and then with a local organization, a Friends Research organization in Baltimore City. And so we're doing a number of things with these organizations. So I think we've been doing this for about 10 years. I've been in the organization for about 5. Actually, we've probably been doing it at a much smaller level for the whole, I'm sorry, I've been here about 15 years. So the first 5, we did have some very small grants that pretty much paid for staff, like salaries and benefits for peer recovery specialists, which fortunately Maryland moved to reimbursing for peer services through Medicaid about 6 months ago. So we haven't had to have those grants any longer. But so for us, it was really more about looking for opportunities in the community where we could provide more services for the population that we serve. We serve a very, it's a primarily Medicaid population in Baltimore City. So there are folks that have long histories of substance use disorder, a lot of mental health comorbidities. And so for us, it was about trying to increase, can we offer some mental health services by using social work? Our federal grant, one of our federal grants, we're an we actually now have our second 5-year SAMHSA grant that just started. And we are building on the first one where we're offering hepatitis. We started offering hepatitis testing and treatment about 5 years ago, and we're continuing to do that. And we're also doing a lot of HIV case management, care coordination, and health literacy around that. So for us, it's really been the whole impetus behind this is what are the things that we can, we see a need within the patient population, and what are the things that we can do, to help meet that need. Many of the grants we've been able to build in transportation services so that we can help our patients either by Uber, getting back and forth to the clinic, or getting to medical appointments outside of the clinic. Currently, I think we have about 6 grants right now, totaling probably close to $750,000 at this point. And we are managing those. We do have overhead built into the grants or indirects, whichever you call it, in your organization. So that does help with some of the administrative things that we have to do. And it is always a challenge, as I think Mustafa mentioned in one of the slides, the administrative burden. It does take, it takes a long time sometimes to get all these things, all these budgets and manage them and make sure that you're allocating, the expenses in the appropriate places. But we've been able to hire some part-time help by using some of the funds, with some of the funds that we've had, with some of the grants. So that's been very helpful. I think I answered the question.
Yes, you did. And I'd like to turn to CJ and ask her to address the same set of questions. CJ?
Thank you, John. That is a loaded question, a whole bunch of questions. So I will try and hit all topics. Here in Arizona, Access is the Medicaid agency. We're a state agency. We also function as the SSA and MHSA for Arizona by delegation of our governor. Access works in partnership with 7 managed care organizations, and we do that under an 1115 demonstration waiver. So along with Medicaid funding, we can pass all of our non-Medicaid funding through these organizations in a braided model. We've been doing that for over 20 years here in Arizona. I haven't had a career that long yet, so I will do my best to talk about the history of how we got there. But our braided funding includes Medicaid, our big block grants, the Scepters mental health block grant, discretionary grants like our state opioid grant, state general funds, and even county and local funds. And so we're able to package all of that and give that to our managed care organizations who have a network of providers that focus on behavioral health and particularly also substance use disorder treatment. And really what we've found there that we're able to do is fill gaps for uninsured, underinsured, and those that lose services during courses of treatment or they run out of commercial payers. So we call that the uninsured. And we're also able to use those non-Medicaid dollars to fill gaps that maybe aren't necessarily related to traditional treatment like housing, acupuncture, and childcare. Those are big ones here in Arizona. We all know room and board can be a barrier for folks that need residential treatment, and childcare definitely has been a known barrier for parents to stay in treatment and really focus on their recovery for lack of childcare. So those are huge. Again, I'm not 100% sure of the impetus of why we started doing it, but I do know that Arizona's entire behavioral health system has been really built on, no wrong door and meet me where I am and individualized treatment plans. So with this braided funding going down to the provided level, our providers are able to just welcome anybody through the door and say, what is it that you need? And then figure out on the back end, how can we pay for it with these different funding options based on who you are today? So it really allows a person in recovery to focus just on their recovery and really take advantage of all the different programs in one place. And we found that to be very beneficial here in Arizona.
Thank you, CJ. I'd like to ask the next question of you too, so hang in there. But can you elaborate on the strategies you employ to effectively communicate and coordinate with stakeholders? federal, state, and local levels to align funding priorities in order to utilize braided funding for substance use disorder services. CJ?
Yeah, I think that definitely starts with community and treatment participant feedback, right? So here at Access, we maintain as a high priority of holding community feedback sessions, posting different policies and ideas out for public comment to really gather what is it that our community is asking us for and what will make them successful in recovery. We work really closely with other state agencies to share that information and even pass that up to our legislative representatives and SAMHSA, of course, our federal partners, and share with other states really what's working for them. So we really love that, the cross-state training and best practice sharing. But we really find it important to the proper and early communication of funding changes that are impacting providers and definitely new best practices that aren't fully supported by current funding sources. And so it's kind of a spider web of gathering communication, really filtering that down to digestible material that goes in all these different directions up. So again, at the state level, depending on your state's organization, getting that through our governor's office to our legislator and so on. And then also, of course, working very closely with SAMHSA and our other federal partners to advocate for expansion in coverage for these type of services.
Thank you. Vicki, I'm going to present this next question for you. Number 4 that we have on our list. But can you speak to the benefits or positive outcomes the use of braided funding has had on the accessibility and quality of substance use disorder services for individuals and communities within your state of Maryland?
So I can speak within my program
Yeah.
because I'm not a state entity. So I can definitely speak within our program. I would love it if other treatment centers, substance use disorder programs in Maryland would be looking to do this kind of stuff. But, you know, it's been amazing for us in terms of the increase in the services that we can offer. I think, CJ, you said this a minute ago, doing surveys of the patients, what are their needs, things like that. And we've been able to you know, we've always done, well, I shouldn't say always, the past probably 7 years, we've done walk-in admissions for substance use disorder. We are in an area where there's a high opioid overdose rate. So we decided a long time ago that we were just going to welcome people in the door when they came, and we would admit them when they walked in the door. So we've already been doing that for some time. And I think that having the braided funding enables us to continue to do that because we can use funds that, you know, when we hire a new practitioner who can see patients for, you know, HIV or hepatitis C care, that person can also do admission. So it helps in many ways. I think when we started treating hepatitis C, and, you know, we've cured people, and that's huge. And so being able to do those kind of things for the population that we serve, the health literacy and the case management services, as many of you know on this webinar, that folks that come into treatment often have neglected their physical health, their mental health, their emotional health for many years. And so we're able to, we have more staffing to get them connected to resources. You know, in all of the grants, not all of them, but in the larger grants that we have, we've been able to build in peer recovery support services, not just to, you know, talk to the person about, you know, how, you know, resources in the community, but also for outreach. So when someone's missing for several days, we can actually go out in the streets looking for them, saying, hey, you know, come back. And if we find them, we can send an Uber or, you know, a Lyft or something to go get that person to bring them in. I really think that having all of these different sources, although sometimes it, you know, it is like, whoa, you know, which pot are we pulling from here? But having that, the staffing has made the big difference, and the you know, the patient population that we serve, you know, they have many needs, and we've just been able, I feel that we have just been able to serve more of those needs. And, you know, we're really looking at them holistically, you know, by being able to provide some of these medical services as well.
I was sorry, Vicky, about giving you the whole state of Maryland, but
That's okay.
what, what, so
They
what
don't want me
areas?
there.
Yeah, I think in terms of counties, being from Wisconsin, but what areas do you cover briefly in Maryland?
So for us, we are located in the northern district of Baltimore City. We have I would say the majority of our patient population, probably about 75% come from Baltimore City. And then we have Baltimore County, Anne Arundel County surrounding us, even a few folks from, our further counties like Frederick or even a couple of people from the Eastern Shore of Maryland, which is, can be 2 to 3 hours from us.
Right.
And I think it's because, there are people, they've been with us for a long time. That's one of the great things about being an opioid treatment program. You get to see people over many years. I mean, we've been around since 1991, and we have folks that have been there since 1991. And so you really get to see people over a period of time. And so sometimes when they move out of the area, they will continue to come and get services from us because they like us, they're used to us, they appreciate the services that they get. Primarily, though, our population comes from the city.
Well, thank you, Vicky. I'd like to ask the next question of CJ. How do you see the sustainability of the braided funding model for substance use disorder services in the long term? And what, if any, measures have been put in place in your state to ensure ongoing support?
John, that's a question that I have to ask myself almost every single day. Sustainability of the braided funding model. Some of the things that Access has done is we've added many of the supportive services like peer support and crisis mobile teams and things to our state plan under the Medicaid 1115 waiver, which has really helped. And we've done these kind of state plan amendments and supported by really using our grant and state-only dollars to demonstrate positive outcomes with these programs and implementing the evidence-based practice. And this has really allowed us to support more through Medicaid and maximize those other funds to continue more innovative programming. Like with our SOAR grant, for instance, we've been able to use SOAR funding to do OTP peer mentoring programs to expand our OTP network, where provider agencies are actually financially able to benefit from helping other provider agencies stand up and implement some best practices. We recently, last year, were able to stand up some mobile MAC clinics. I mean, that's super cool, which you can't do without this kind of braided funding model. Outreach, I know Vicki mentioned outreach and engagement, harm reduction programs, where when you finally engage with one of those people, those members that aren't really engaged in treatment that are ready today, having your outreach person able to bring that person right back to the treatment facility as she spoke about and get them starting in treatment when they're ready has been so amazing. And we've taken that kind of a model and that data collection on the positive outcomes of the sustained recovery in that model to really advocate even at our state legislators level for just sustainable appropriations. We've been very fortunate that our federal partners have given us great deals of money to get these programs running, but they're not a promise, right? So we've definitely tried to work those into our general public health system for sustainability.
I think you raised a couple good points there, CJ. I'd just like to point out, I do think that the 1115 Medicaid waivers have been a big boom across the country for a lot of substance use services and receivers of services. Of course, that still doesn't cover everybody and not all services, so you still got a mix and braid funding, I think, to provide a wider range of services for people, or some who aren't eligible, of course, for Medicaid. So, thank you. My next question is for Vicki again, and I'm particularly glad to hear that you run an opioid clinic because I like opioid clinics because my daughter operated a couple of them in Wisconsin, Madison, and Milwaukee, and was a clinician. What lessons did you learn, Vicki, from your experience in braiding funds for substance use disorder services that could be valuable for other providers looking to implement similar strategies?
So it's a process. I'm still learning every day. As I said, I wasn't even aware that we were doing this or what I guess I wasn't aware it had a name, but I think that for me, it's really been about that there are ways if if you're out there, if you're looking for things and you are, you get yourself on all these email lists and, that there are ways to find funding to provide different services. I have to give a shout out to Maryland. I don't know how many people in this, participating or listening in are from Maryland, but Maryland, we've done a lot of work. Maryland is very progressive in my mind, in my opinion, around making sure that people can access treatment, in terms of getting people Medicaid, and we can bring people in uninsured. We can do all kinds of great things. We have behavioral health homes that are funded. Our peer services, as I said earlier, are now funded. I think that the biggest thing was I am very fortunate. I have I call her an Excel savant in my in my organization, and because I am doing, numerous budgets. I have my opioid treatment program budget. I have my intensive outpatient program budget. I have my SAMHSA grant budget. I have my a collaboration with Hopkins. It's a not NIH grant on workforce development and employment services. So having all of the, having this great spreadsheet where I can just plug in the numbers, you've got to be able to do that. And I think I saw something someone said in one of the questions about, is there a spreadsheet? I've created, well, I haven't created it, but I have someone in my organization who has created this great spreadsheet for me where I can track every single grant that we have, and a percentage, for who's, what staff positions, are we paying a percentage of. Having these services, though, I think have been very beneficial to the staff as well, because, having peers, having more providers even. There was a point where we had a grant that we were actually doing weekend admissions for opioid treatment. So we had providers available in the building. After 5 years, we did lose that grant and we did have to scale that back. We are not doing weekend admissions now. We're just doing walk-in admissions Monday through Friday. But I think it's about, just taking that leap out there, from my perspective, being involved with our local universities, with Hopkins, with the School of Public Health, and with the University of Maryland, and with our local, like I mentioned earlier, there's a small Friends research organization. Getting involved with them and working with them has just been really, I think, critical in terms of us getting the support that we need through different revenue sources. And involve your staff. I mean, when I see a grant opportunity, I always say, hey, who wants to help write a grant? People aren't clamoring to do that, but there are a couple that, will come to me and say, I'm interested. I'd like to do this. I'd like to learn how to do this. And so, using those folks to help you with that. So I think from my perspective, I guess I just think that when you think about the services that your folks need, and if you can find things out there, and again, in Maryland, we're also very fortunate because we have, an opioid overdose organization that also has funds that we can access or write grants for. They're funded by the Opioid Restitution Fund and SOAR dollars. Again, I think CJ mentioned this. We're grateful to our federal partners who make these monies available in our local jurisdictions. And I'll stop there because I think I'm rambling.
Very well. I'd like to give a shout out too, since you did, to all my colleagues from my former home state of Indiana who are on today, as well as my colleagues from here in Wisconsin that I saw sign on. We like to think in Wisconsin that we're the best too, so I guess it's not necessarily the case. Maybe everybody does. And I know that CJ State is very famous for its innovation in the management of braided funding. I would like to go to our next question. I have one more, believe it or not, for both of you. How do you navigate potential complexities in the financial management associated with braided funding? This came up a lot in several of the states that we interviewed. And of course, being a former administrator at the local level, I had to deal with this a lot. So I'll start with you, Vicki, since you're here, and then we'll go to CJ. Mute.
My apologies. So I can, again, only speak from the programmatic level. And again, for me, it's about having the, you know, keeping those budgets and keeping them very separate and tracking the spending. And I have a great finance team in our organization that has made that possible. And I can only speak at, you know, the program level.
Well, that's fine. And actually, I was speaking at the program level too.
Oh, okay.
As
All
a
right.
former provider, because managing all these, you know, balls was something else at times. You
Yeah,
know, that's
it's
all I can say.
stressful. It can be stressful, especially if a lot of reports are due at one time. So I think you know, managing a calendar and, you know, just being super organized. And I have to say that, you know, with some of the indirect funds that we get, you know, I have been able to, you know, to support some additional staff that have been very helpful with this. And most of the grants have, you know, like a project coordinator. I'm the project director on several, but we do have a project coordinator that helps with that as well. So I think it's partly also building those things into the grant when you're writing it. You know, you have things that, you know, they want you to have, but then you can also oftentimes build in some other things. Or working on those job descriptions to make sure that you're getting the help that you need. I learned that very quickly with the first grant, that I was like, oh, the first very large grant, I should say, was like, oh my gosh, you know, it's like, be careful what you ask for, you just might get it, because now I have to manage this. So I think it's being super organized and having the support within your organization.
Thank you. I agree. And you better learn quickly. Vicki, excuse me, CJ, I'd like to ask you the same question about navigating potential complexities in financial management associated with braided funding. And again, your state's very famous for this statewide, you know, planning and controlling of all these different pots. So, CJ?
Famous for it because it's been done long before my time, John, so I can take zero credit for that.
Okay.
What I can say is that the Access Finance team has been magical in creating a financial reporting guide that goes along with our braided funding model. It has specific requirements for our managed care organizations. It also has flow down requirements for specific reporting guidelines for the providers for these various fund sources. I think what I do the most to impact this is really listening to our providers and taking that feedback back and looking at all the various different reporting requirements and financial separation requirements and trying to advocate for alignment between CMS, SAMHSA, and the various discretionary grants, right? So the bottom line is really organization at the provider level. As Vicki spoke to, her team has a great Excel wizard that created a document that helps them keep people in the right bucket. And that's really what our financial reporting guide gives down to those managed care organizations. Here are our core requirements. Here's exactly what we require of you. And of course, those are all published on the Access website if anybody would like to go look for those. But it definitely helps the providers having a guide right here saying, this is what I'm supposed to do with this. Anything innovative that you try in your state is going to add administrative burden to the programs at the program level. And as Vicki stated, having the right staff really helps. But you know, as a state agency, we really find it's our responsibility to give as much clarity on what's required. And then on the back end, again, listening to the providers, hearing what they're saying about burden, and then advocating back up for alignment and making that as easy as possible for them so that they can do the work that they're really out there to do and help people in recovery.
Well, thank you very much. That was a good example. I don't want you two to go away because we're going to change soon. I really appreciated your participation today, but we got a little more to go. Questions from our audience. So I'm going to turn this over to either Finn or Emma at central headquarters there to go to the questions from our audience. And thank you again.
Thanks, John. Yeah, we're getting some great questions from the audience, so keep them coming. Do you want me to pass them directly off to our panelists here? I think I can do that. So we have a question about prevention funding for SUD. Maybe we can start with CJ. How do you raise funding for prevention services? Like, what are the funding sources and what kind of activities might you be doing?
So between our SBG or Scepter's block grant and our SOAR program, we have quite a few different prevention activities going on. A good majority of our Scepter's block grant prevention set aside goes back to our governor's office for our governor's office of youth, family, oh man, I always just say GOYFF. I'm gonna be upset about that. I'll remember as soon as we get done, but it goes back there because they really do a lot more than just substance abuse prevention. They do a whole lot of community stuff in the Office of Youth, Family, and Faith over there. So some major activities that we've done in the prevention space really go to working with schools and community coalitions and doing direct outreach with our youth and families just across communities. We do a lot of faith-based outreach to get our faith-based partners out there in the community up to speed on the latest best practices for prevention activities for children. A huge one that we've had here in Arizona the last couple of years is Paxis, Good Behavior Game, that has worked with our educators and our community partners to really get in front of talking about and preventing substance use before our young people are exposed to having to make that choice. So it's not a lot of braiding in the prevention space here in Arizona because prevention is so much separated from treatment. Really, under our SOAR program, we have more prevention activities that target our older youth, and then also kind of partners with our harm reduction programs because we're often in the prevention space hearing about family members or loved ones who are active users. So we use that SOAR harm reduction program to really partner with prevention, identify folks that need that outreach, and try and engage them. And with the support of their family, we find that to be extremely successful.
Great, thank you. Vicky, I have one maybe I'll throw to you. Do you lose any funds from law enforcement service sources?
So we have had funds from that we've used in criminal justice in terms of working with our local detention center to make sure that folks are getting medications for opioid use disorder. We've had numerous grants over the years, particularly working with the organization I spoke about earlier, the Friends Research Institute, because that's one of their big priorities. So in terms of local law enforcement in general, no, but yes, in the criminal justice system, we've also worked with the Federal Bureau of Prisons to help them develop. We did trainings and webinars and had them come and observe our clinic and see what it was like in an opioid treatment program as they were preparing to open or to provide all the medications for opioid use disorder in the federal prison system. So in that respect, yes. And it's a critical thing. And in Maryland, there's a huge move right now to make sure that all of the state detention centers, prisons are offering all the medications for opioid use disorder.
Thank you. CJ, I guess I should open it up to you as well. See if you have any thoughts on that question.
Sure. We don't really use a lot of law enforcement funds for us, but we use our braided funding model to really support law enforcement here, particularly in our diversion programs. Our managed care organizations and providers work with law enforcement every day to do CIT training. Our goal really through our crisis and substance use and mental health in general programs are all to keep people that really need treatment out of jail. So we do use a lot of our braided funding to support that training for law enforcement, identify training for law enforcement to know who to call, and that relationship building really, because law enforcement really needs to trust your provider network if they're going to hand off a person, right? It also is speed of service with law enforcement. So we do a lot of work with our providers to train on customer service and language when speaking with law enforcement. Law enforcement officers are trained to handle things and move on, as clinicians, we're trained to wait, assess, observe, and treat. So bridging that language gap has been a big educational piece where we've used braided funding with our providers that are really good at that to go out and train other providers as well as law enforcement. And we've seen huge positive impacts on our diversion programs, keeping people out of jail and getting them into treatment.
Thanks. Question for maybe either of you, if you want to jump in. Can you speak? I think you touched on it a little bit, but can you speak more to how you use braided funding, sort of bridge that gap for people who might not qualify for Medicaid, but maybe they can't afford other SUD services?
So for us, we're, in Maryland, there is what we call, the Medicaid calls an uninsured status. So we are able to admit people and then we can work with them. And honestly, for us, the majority of the folks that we serve do meet the criteria and are able to get Medicaid. We do have a, sliding fee scale, and sometimes it's, nominal, like really nominal for folks that really cannot pay and are not eligible. But for the most part, we work with our local organizations, Healthcare Access Maryland, other organizations to get folks, and our peers do this as well, to get people medical assistance or, Medicaid. And that includes, getting them a license or a birth certificate or a federal or a state ID license, birth certificate, whatever it might be that they need in order to go and apply for that.
And I would echo that when we're talking about completely uninsured folks. I think in addition to that, braided funding really has an awesome role in the space of underinsured. We see a lot of folks, especially in substance use treatment, whose commercial insurance plans cover only so much of the treatment that they need. And they really don't cover a lot of the supportive best practices like peer support, right? Or room and board that we're able to leverage our non-title block grant and braided funding for. So really, I think that's the primary space we see on the draw. That's a continued need for the federal funding and the state support that we see is those services really. Sustained recovery just cannot happen without supportive services, right? There's only so much a 28-day inpatient stay is going to do for someone, with their housing insecurities, job and employment insecurities. And so we use a lot of our braided funding to support those folks that are underinsured to implement those best practices and the SAMHSA toolkits really across the board that support those that commercial payers simply haven't adopted.
Thanks, CJ. And thanks to our panelists and to John for this great discussion. We have a few more questions that we don't have time for, but we will try to get back to everybody who asked a question. But we're going to turn it over to Dr. Olson again to take us into the closing piece of this webinar.
Great. Thank you all so much. This has just been an amazing panel and discussion, and your questions are just so right on. I just want to express, SAMHSA's heartfelt gratitude for just this exceptional discussion that we've had today regarding braided funding for substance use disorder. As a nation, it is imperative for us to prevent and treat people who are affected by this health condition, by substance use disorder. And SAMHSA has diligently collaborated with our federal partners to prioritize the financing of these vital programs. And so today, our discussion has shed light on the possibilities of using braided funding models. In addition, I also just want to extend SAMHSA's sincere appreciation to our federal partners for their ongoing collaboration and shared commitment in achieving our goals. And a special thanks to SAMHSA's dedicated staff who are instrumental in overseeing and monitoring these programs and ensuring that we can share vital information that positively impacts individuals and communities. So as mentioned, you will receive an email in the coming weeks with links to the report, webinar, and the slides from today. We encourage you to share those resources with your colleagues. And please check out the CFRI webpage on samhsa.gov and on the link that was on the slides to see additional projects. And we really hope to see you next time. So have a wonderful afternoon.